Hello everyone. Today I'd like to deliver part 2 of the lecture from chapter 11 on childhood biosocial development. We're talking about the middle childhood years here from about the ages of 6 to 11. I'd like to discuss in specifics developmental psychopathology, which is a subfield of developmental psychology where we use our insights into typical development to try to understand and help individuals who have developmental disorders, such as an intellectual disability, an attention deficit disorder, a learning disability, or even something like schizophrenia or autism, which are thought to be neurodevelopmental disorders, meaning that they affect multiple aspects of a person's nervous system. So developmental psychopathology is the study of developmental trajectories that are atypical. And in addition to bringing what we know about typical development to atypical conditions, we also actually can learn a lot about typical development by studying atypical populations. Now, there are several general principles of developmental psychopathology. The first is that abnormality is to be expected. As human beings, there's going to be a lot of variation in our traits and capacities and potentials, and there will always be, with any human characteristic, individuals who have a high amount or an excessive amount of that characteristic, as well as individuals who have an exceptionally low amount of that characteristic. So think, for example, about height. You'll have individuals who are really, really tall, off the charts, extremely tall. They would be thought of as having an atypical growth trajectory. Similarly, individuals who are short in stature and don't grow to the expectations might be seen as abnormal on the other end of the spectrum. So when we think about intelligence, for example, we know that most of the population falls within one or two standard deviations of the average score, which is 100. But there are individuals who are intellectually gifted, who have IQ test scores that are 2 standard deviations or more above the mean. And by standard deviation, I'm referring to a statistical concept that helps us understand the range of scores we should expect in typical development. When things go beyond 2 standard deviations, either above or below, we are in the area usually of clinical abnormality or things that require intervention. So abnormality itself is normal. It is to be expected. And what we want to try to do is figure out how to support someone whose trait is either too high or too low relative to the general population. We need to help them adjust. It's also important to keep in mind that disability is actually a cultural construct. It really depends on how people in the culture view a certain area of functioning as to whether or not a certain trait is a disability. So for example, if 2 deaf parents have a child who is deaf, those parents may not perceive the child's hearing impairment as a disability. In fact, there's a whole culture in the deaf community for valuing the way that individuals who don't hear sound can communicate using sign, lip reading, that sort of thing. So disability is a cultural construct. It's determined by the people who are looking at the situation, and because of that, it could change year by year. It's also important to know that I think an unstated general principle here is that we all continue to develop across our lifespan. And that is true for people who have a developmental disability as well. So functioning changes over time. We always want to give people room for growth. Another general principle of developmental psychopathology is that as individuals grow up, their development is being impacted by lots of external forces, their environment, the parenting they receive, the schools they're in, the neighborhood, their friendships. Those external factors are going to interact with their internal factors, such as their genetic potential, and therefore we can't really determine exactly what adult outcomes are going to be like for people with different developmental histories. It could be that an individual who's identified as having an attention deficit at age 5, it could be that that person will have a harder time becoming employed or going to college. Or it could be that that person absolutely thrives in a job that fits their learning style. So it's really impossible to be predictive when we are thinking about the futures of individuals with different developmental conditions. We have to take into account all of the individual factors that are going to impact upon their development over time. So as we identify people whose development is different, we want to provide interventions that are relevant to that individual and to their family. And so you really try to direct your interventions to what's most important to the people receiving those interventions. Another really important philosophy underlying the study of developmental psychopathology is the concept of neurodiversity. When we refer to this, what we really mean is that every single individual has neurological strengths and weaknesses that need to be considered. In other words, there is no one perfect brain. We're not all trying to have exactly the same nervous system. Neurodiversity is really relevant when you are working with learners who process information differently, because we have to adjust from perhaps teaching something through language, which maybe a typically developing person would learn easily, to maybe teaching something through pictures or video modeling or through demonstration, like I do when I'm working with somebody with an autism spectrum disorder, where oftentimes learning through language isn't the best route. Understanding neurodiversity also means understanding that just because a person has a particular diagnosis, that doesn't mean that they automatically have all of the strengths, all of the weaknesses associated with that condition. There is individual diversity within groups of people with the same condition. So for example, in my world of working with people with autism spectrum disorders, I work with some people who are really intelligent, highly verbal, and want to discuss theology and philosophy, and yet can't tie their shoes, make a sandwich, or pour themselves something to drink. Their difficulty in the connectivity of their nervous system has to do with motor planning, with picking up on social context and cues, with learning procedures. That's just one subset of individuals with autism. There are also another subgroup of individuals for whom language doesn't come easily, and maybe they master those motor plans I just mentioned really quickly, but they have a very hard time understanding symbolic systems or generating new ideas. They can, however, complete routines the same way every time. So, neurodiversity not only applies to the entire population, but it tells us something about individuals within diagnostic groups. There is still diversity. Now, this idea about developmental psychopathology, typical and atypical development, really does become relevant in middle childhood, particularly because in school we start to group children with regard to ability. We start to observe as teachers and parents where some children need additional help and support to be able to learn new things. There are some disorders that the earlier we can get engaged with the child, the better impact we can have on their outcome. So for example, there's a wealth of data suggesting that for children who are late to talk, engaging them in speech therapy, both one-on-one and in groups with peers, can help them master important language milestones prior to entering school. And then throughout school, those individuals who had a hard time learning to talk often need some support in learning how to read, in literacy. And so therefore, if you've started early with speech therapy, you've laid the groundwork that when you get to reading and writing, you now have a foundation to build upon. And we know in the area of dyslexia and learning disorders that the earlier we can get in there and support a child with that different learning style, the better. Primarily so they can meet their academic and functional objectives, but also for their self-esteem and self-concept. If a child experiences a lot of failure in school or doesn't feel smart or capable, Middle childhood is the time where those beliefs about themselves can get really cemented and can have a lot to do with their social and emotional well-being. So we want to try to address the special needs that we see in front of us as soon as we can, and we want to try to use a strength-based approach so that individuals can feel confident that they can tackle the challenges ahead of them. Now, there are two very important terms I'd like for you to understand from this chapter, multifinality and equifinality. What do we mean by these? Well, basically, multifinality means that you're going to have the same causal factors can result in lots of different outcomes. So think of finality as the word for outcome. Multiple means multiple outcomes. So multifinality is many different causal factors same causal factors leading to many different outcomes. So an example of multifinality would be attention deficit disorder, where we know that there can be some biological factors such as the genetics underlying the attention system, such as the experience that somebody has in learning situations. Those same factors can be associated with either having an attention deficit disorder or possibly having a language disorder. So you have the same set of risk factors leading to multiple outcomes. That's multifinality. Equifinality is when you have many different causes leading to the same outcome. So here's where we might think about intellectual disability, where a child can end up as having an intellectual disability because of genetics, because of a lack of environmental stimulation, because of an abusive environment, because of a physical illness, such as a metabolic problem. So there you have many different causes leading to the same outcome, an intellectual disability. Equifinality, same outcome. Multifinality, different outcome. And it's important to keep in mind that these things are very complex and they add to the diversity of understanding developmental psychopathology. Well, let's turn our attention to a couple of the highlights from this chapter on attention deficit disorders, because this is an important condition for us to have a handle on as people who are interested in development in the middle childhood years. So attention deficit disorders refer to a group of conditions where there could be difficulties concentrating for more than a few moments, which we might describe as inattentive. It can also correspond to difficulties in switching your attention, where maybe you can be really, really well focused on a favorite topic, but as soon as you leave that topic and try to do something that's less interesting, your attention wanes. So it has many different manifestations, and it can look like the person is inattentive, can look like the person has a hard time shifting their attention. It can be associated with impulsive behaviors where the person is acting without pausing to think. And in attention deficit hyperactivity disorder, it also involves a motoric restlessness where movement is a real need. And we often find that for a child with ADHD, we need to build in exercise breaks or movement breaks in a philosophy we call a sensory diet, which basically means we're coming up with a prescription of sensory motor activities for this child to have during the day, so that if he needs to be able to pay attention during spelling class, that means he has to have a 15-minute walk around the school prior to spelling, because he'll pay better attention once that movement need has been met. To receive a diagnosis of an attention deficit disorder, you must present with multiple symptoms out of a whole list. Those symptoms have to present before the age of 12. And it's often very important to make sure that when you are looking at a child's attention system, that you are also thinking about their home environment. Because, as you might imagine, a child who grows up in an environment that is abusive or neglectful may learn to survive that environment by not paying attention to what's going on around them. In other words, they learn to adaptively switch their attention to something else. In other words, they almost teach themselves to be inattentive. So there are times where a child may present in school as having an attention deficit disorder, when in fact it's a clue that that child is growing up in an environment that doesn't feel safe, and therefore they need to move their attention so that they're not in constant stress. So we have to be quite thoughtful when we make this diagnosis, that we are thinking about not only the whole child, but the whole child in context. So attention deficit disorders are one of the more common disorders in the United States in childhood. From the ages of 4 years to 7 years, approximately 7% of children meet diagnostic criteria. As children get older, those prevalence estimates increase, so that on average about 13% of 10 to 13-year-olds meets diagnostic criteria for an attention deficit disorder, and approximately 15% meet it between the ages of 14 to 17. Now, there is no current biological marker for ADHD, even though we know that this set of disorders is caused by problems in the brain. We don't yet have an objective way of detecting them. Instead, we rely on parent report, student self-report, and behavioral observations. The rates of ADHD are actually higher in the United States than in most other developing nations, and the rates are increasing, both in our culture and in other places, leading some people to wonder if there are differences in our culture that are impacting our attention span, such as the amount of time we spend interacting with computers. As we see increases in the worldwide diagnosis for attention deficit and hyperactivity disorder, we do become concerned, because these things can be associated with adverse outcomes. For example, I mentioned that a child growing up in trauma may appear inattentive when in fact the inattentiveness is a way of adapting to the trauma. So a misdiagnosis in that way, something that pathologizes the child but doesn't make any changes in the home environment, is not going to help that child long term. There are some concerns that increasing ADHD diagnoses leads to increasing medications, and there are some concerns about drug abuse, where people are actually pretending to have it to get the drugs. Well, it turns out several studies have been conducted that show if an individual who truly has ADHD receives the right medication for that ADHD, the incidence of substance abuse for those individuals goes down over time. So treating ADHD medically can prevent substance abuse in that population. For individuals who don't have ADHD, access to stimulants could lead to a drug problem. So doctors have to be very careful in managing these controlled substances. So it's important to keep in mind that diagnosis should be revisited from time to time, and we want to observe the child in more than one environment, both school and at home, so that we understand the context. Now, attention problems often co-occur with specific learning disorders. At other times, specific learning disorders happen without attention problems, and the DSM-5, which is our diagnostic manual, stands for Diagnostic and Statistical Manual, version 5. It includes a diagnosis of a specific learning disorder. Could be problems in perception, processing of information, or lower achievement than expected given a person's overall IQ. Disability in a specific area, like a math learning disability or a reading-based disability, can make it harder to achieve in school, and as I've mentioned before, can be really hard on a child's self-esteem. Having a specific learning disability can qualify a student for special education, and the desire there is to provide enough supports and modifications that the child can keep up with the pace of those children around her. Oftentimes, we do not need a formal individualized education plan for a specific learning disability. Many times in schools, we can use what's called a 504, which is a modified plan that can be done in the general education classroom and requires less intensity of monitoring than a full individual education plan. We also rely on the school's RTI program, which is response to intervention. This is based in the idea that all students in general education should have the opportunity to get a little extra help. And if using the RTI, response to intervention, that means the teacher does a little extra help, then you look to see how well the student did with that. If they were able to accomplish that educational goal with just a little help, then there's no need to go through formal special education. Instead, you continue with the response to intervention approach, teaching the general curriculum and adding supports as needed within the general curriculum. When we think about specific learning disabilities and attention deficit disorders, it's really important to think about how no single intervention is going to work for every child. And that's why the individualized aspect of special education is so important. To help a person with an attention deficit disorder, you often need to be working with the parents and the teachers as well as the child. Medication doesn't solve the problem, but it can help the child's biological system be ready to learn some of the interventions that parents and teachers can provide. So we do want to remember, as equifinality would suggest, many different causes to the same outcome. We're going to need to explore many different interventions for any given child. Now, as you might imagine, there can be some opposition to using psychotropic medicines or drugs with children. And there are data that suggest that some children may be over-medicated. There are also children that are undertreated, that a little bit of medicine might really help calm their distress. Depending on how the media covers it, there can be some suspicion of drugs and suspicion of the people who prescribe those drugs. So only physicians and psychiatrists can prescribe medication for attention. Psychologists and educators and occupational therapists, speech therapists, are often the first to notice the attention problem, and their role is to help the family get in touch with a physician, provide the information so that the possibilities of medication can be explored. There are actually several different medicines that can be deployed for attention deficit disorder, and the data on these for children in the middle childhood years is actually really quite strong, can really help a child focus within 4 to 6 weeks. The most important thing is to try one medication at a time, to carefully monitor for side effects, to track the child's response since the medication began, to stick with it for about 4 weeks, and then evaluate if it's something that you need to keep, increase, or decrease. Now, the prevalence of children who are receiving medications for a behavior or an attentional problem has increased over time. So what you can see here from this graph is looking at the United States geographically. And in the South, 9 children out of 20 is on medication. That's really, really high. That's unbelievably high. So that would tell me that people perhaps are not considering some of the psychoeducational, psychosocial, or non-medication approaches that could be used to help support these students. Now, a couple of other conditions I'd like for you to be aware of as they do impact a child's development over time. Dyslexia is a specific learning disability, and it has to do with reading. Now, there's a common misconception. People think it has to do with having letters reversed visually, and it turns out that's not dyslexia at all. It has nothing to do with seeing things backwards. Dyslexia is actually caused by a phonological problem. It's an auditory problem. There's a difficulty in the brain in transferring the sounds into meaning. So that underlying phonological process of associating sounds with meaning is where dyslexia resides. So phonological treatments are used, helping children to learn what different sounds mean, how symbols on paper are translated into specific sounds is what speech therapists would work on. Dyscalculia is a specific learning disability related to math, and its probably in a very specific part of the brain. It does, however, tend to co-occur with reading problems, so it could be a sign of overall poor connectivity neurologically. Dysgraphia refers to specific difficulties with the motor planning or the mechanics of handwriting. And you will often find that a student with a disorder such as attention deficit disorder or an autism spectrum disorder often also has dysgraphia, so that the motor planning aspects of putting pen to paper can be really effortful and can be very, very challenging. With something like dysgraphia, when a child's handwriting is so hard for them to produce, that's when we often recommend teaching keyboarding or using a computer or a tablet, because you can then help the student focus on expressing their ideas without getting stuck in the process of trying to write things in a legible way. In special education, there are also a group of students that are described as gifted and talented, and this has to do with a particular IQ cutoff, which each state gets to choose. In general, the IQ cutoff is 140 or above, and there are different definitions of being gifted and talented. Sometimes it has to do with using a different way of processing, coming up with more convergent or sideways thinking. It can be associated with some heightened creativity, or heightened problem solving. It usually has less to do with learning rote facts and more to do with being able to conceptualize information effectively and quickly. Children who are gifted and talented, whether it's in one area like art or music or reading and writing, or if it's across the board, they often need time and support to develop in their area of strength. They will be bored probably if they don't get stimulation in that area where they are really advanced. So the strategies are to provide some accelerated activities through special education, such as an individualized gifted plan or a group plan. And you can also sometimes basically work out a mentoring kind of program where a child who's gifted in a certain area gets to have some one-on-one time to build that capacity with a teacher. So in conclusion, developmental psychopathology is a field of great scientific interest. It has lots of practical implications, and it basically helps us think about children who develop differently from other children. As a psychologist, I find this area fascinating. And middle childhood is the developmental period where these individual trajectories are really emerging. It's the time where we want to be intervening where we can, promoting the child's strengths, helping their self-esteem get stronger if they're dealing with weaknesses, and then bolstering or supporting those areas that come to them less naturally. Now, there's a lot of content in this chapter, and if you'd like to learn more, I'm going to put up some lecture material in Module 13, the very last lecture, on autism spectrum disorders. I'm also going to post a case study about a child who grows up being exposed to methamphetamine so that you can see in an example of how that sort of exposure can result in impaired functioning for the child, and then hopefully from that case study see how developmental pediatricians approach the treatment of that individual. So thank you for your time. This concludes our lectures for Chapter 11.